Welcome to Lesson 6, Medications to Treat Thyroid and Diabetes Disorders. Here are our objectives. I'll allow you to look at those at your leisure. And our medications in order of appearance. We have several components to this lesson. You'll first go through this slide set, PowerPoint, and then there'll be a separate one around diabetes, and a third one called the insulin dosing tutorial. This will help you with your homework. You will also view the student presentation about diabetes mellitus type 2. And then there will be a homework assignment which has two parts. One is a discussion board to work on some of the diabetic drugs, and then a lesson in completing an insulin prescription. So we'll start with the pituitary thyroid gland feedback loop to get us into the thyroid medications. This should look fairly familiar to you, back from, again, physiology or pathophys. And basically, in a very simplistic way, we're taking a look at the pituitary gland, which produces thyroid stimulating hormone, or TSH, telling the thyroid gland, if you will, to produce thyroid hormones, one of which is thyroxine, or T4. We need iodine from our diet in order for this to happen. We'll talk a little bit more about that later. And then, of course, the thyroid hormones are carried around the body and contribute to the control of metabolism. In the feedback loop, if there is not enough of the hormone floating around, which is called hypothyroidism, and is the more common of the two disorders of thyroid, then the low levels of thyroid hormone stimulate the pituitary gland to tell the thyroid, by virtue of sending down more TSH to the thyroid gland, telling the thyroid to produce more hormone. Similarly, if there's not enough hormone, if there is too much hormone rolling around, then the feedback loop says, okay, back off. The pituitary says back off to the thyroid and decreases the amount of TSH, or thyroid stimulating hormone. It's kind of like a seesaw. So as the TSH is elevated, you'll see the amount of thyroid hormone decreased, and vice versa. So, in summary, an elevated TSH, or thyroid stimulating hormone, leads us to the possible diagnosis of hypothyroidism, and a suppressed TSH, or low TSH, tells us we are looking at hyperthyroidism. There are other thyroid hormones that are tested and possible to be tested, notably T3 and T4. And clinically, I'll just give you the answer here, that T4 is the most clinically relevant for lab testing in terms of monitoring these two disorders. There are also a number of other lab tests which can be touched upon in other courses. However, here we're going to deal with drugs, and we're going to keep it very simple. Let's look at a couple of cases. This first is a 53-year-old female who's been on levothyroxine, or Synthroid brand, for 8 years. She's been diagnosed in the past with hypothyroidism. A year ago, her TSH was 1.6, and that's right in the middle of the range of 0.5 to 4. So we thought things were going well, and she was monitored on an annual basis. Today, her TSH is 9.6. Her current dose of levothyroxine is 125 micrograms. So her TSH is elevated. We want to ask the patient several questions when we call to discuss these lab results and perhaps take some kind of action. So again, thinking of the seesaw, she now may have not enough thyroid hormone in her body because her TSH has become elevated for whatever reason. So her her pituitary is trying to tell her thyroid gland to put out more hormone. What I always want to know from these patients, and you've probably already thought of this, is, gee, had they taken their medication every day? Are they able to get the medication? Do they take it without food, which is how it's prescribed when you look it up in Hippocrates? Foods interact with this medication or hormone. And it is a natural hormone of the body, although we synthesize it with the levothyroxine. So, our plan right now is going to be to increase her dose of levothyroxine. I usually do this in small increments of 25 micrograms at a time, and then, or 20 to 25% of her base dose. And then we'll follow her up with some monitoring, pretty much just following her TSH. If she was a new diagnosis, we'd kind of want to know where her free T4 was falling, but for ongoing monitoring of hypothyroidism, it's okay to just do the TSH level. So since hormones start slow and act over a long period of time, we want to wait at least 4 to 6 weeks before we retest her TSH. So we'll continue to do that and perhaps titrate her up until she's within range. Here's case 2. A 43-year-old female is on long-term levothyroxine for therapy, and today her TSH is 0.15. So she falls below the norm for the levels of TSH, and we're concerned that she may have too much thyroid hormone floating around, and thus her pituitary is saying, back off, don't produce as much. Could be for a variety of reasons. She could have lost some weight, some things could have changed in her life, she could be more compliant with her medication than she was the last time she was tested, etc., etc. Basically, this is called a secondary cause of hyperthyroidism. She does not have a primary disease here, but her hyperthyroidism is iatrogenic. So at this time, again, thinking about how kind of the long half-life of these hormones, we want to go ahead and she can stop taking the drug for a few days, and then she'll restart at 20 to 25% lower than her previous dose. Certainly, if she's symptomatic, we want to maybe be a little bit more aggressive. But today, she just had a lab test and it showed this result. We're going to, again, monitor her every 4 to 6 weeks. We won't need to do that any more quickly, and get her back into range with a lower dose of levothyroxine. Here's a third case, and this case is one that I actually took care of. A 37-year-old female reported to the emergency department brought in by friends with growing paranoia. She had lost 10 pounds over the past month, which was unintended. Her exam was remarkable for tachycardia, disorientation, and agitation. Other vital signs were normal. So this is a person who had been lost to our care. She had been with us some time past. She had been checked. Her thyroid had been checked because anyone with depression or anxiety symptoms, I kind of routinely screen them. She had been within normal limits in times past, but at this time she shows up and she's very agitated, and as part of their normal labs that they did in addition to drug screening, they looked at her thyroid, and her TSH was extremely suppressed. Now her other vital signs were normal, so she did not meet criteria for needing emergent treatment of her hyperthyroidism, but she certainly needed treatment. So our working diagnosis in this case would have been hyperthyroidism of some primary sort, possibly Graves' disease, which is the most common, an autoimmune disorder. You can also consider thyroid storm, and you can click into this at your leisure, the notes about thyroid storm and its symptoms and signs. And in her case, she does not have high fever or hypertension, therefore emergent reduction of her temperature and blood pressure, slowing down her heart rate, antiarrhythmic drugs, and things like that are not needed. But the same drugs that we use in thyroid storm are going to be used to treat her hyperthyroidism. Again, in terms of additional laboratory testing at this time, we're going to want to know what her free T4 is. There are, of course, a number of immune antibodies to be studied. That isn't something we're going to concern ourselves with either in emergency or in primary care. And in fact, these patients are managed by the endocrinologist. We would identify them if they came into our office, but then send them on to be treated by others. The endocrinologist will have two drugs to choose from here to basically reduce the production of thyroid hormone by her thyroid gland. There are two choices, methimazole or tapazole and PTU. She needs to be non-pregnant or and not considering pregnancy for the methimazole treatment. We'll talk about that in a second. And I want you to think about these thoughts. What if she was pregnant, and based on her chosen medication, what laboratory monitoring is required? I'll make a little side note here that hyperthyroidism can also be treated with surgery or with radioactive iodine ablation of the thyroid, so actually removing the thyroid gland in either way, or taking it out of commission. And then, of course, the patient has to be on lifelong thyroid replacement treatment because the body will not produce any thyroid hormone without the thyroid gland. So methimazole is the drug of choice for non-pregnant females and males, and it inhibits one of the enzymes which is responsible for thyroid hormone synthesis. Now, again, it doesn't destroy the thyroid gland per se, but it inhibits the ability of the gland to produce thyroid hormone by using iodine. And of course, as we said before, iodine is essential for thyroid hormone synthesis. We also can overdo the iodine, and that can cause hyperthyroidism. It's kind of confusing. So this drug has some other minor side effects, but its major adverse reaction is agranulocytosis and neutropenia. And so you might think through and say, okay, I know what I need to monitor, a complete blood count. We need to look at white blood cells and make sure that the white blood cells in the body are adequate. And so sometimes you will see instructions that and should be given to every patient that if they develop any kind of infection, such as a sore throat or any other kind of infection, their white blood cell count should be tested to be sure they have not become immunosuppressed by this drug. It is contraindicated in pregnancy because of birth defects. So the alternative also works a kind of a little different way to inhibit the enzyme that is responsible, and that blocks the formation of iodine from iodide, thus decreasing T4. And this is propylthiouracil, or PTU. It has also got a reaction, adverse reaction of agranulocytosis, although interestingly enough, it is considered safe in pregnancy, safe enough to use. It does have a black box warning. It's probably worth taking a quick look at this. It can cause liver toxicity in adults, and so we do avoid it in all populations, although we still do use it in pregnancy. Occasionally in pregnancy, we also consider actual thyroid surgery and then thyroid replacement. Symptom management is also important. Sometimes short-term benzodiazepines, which we will study later in this course, and those good old beta blockers. I want you to think about why beta blockers might be used for symptom management in this population with excess thyroid hormone. That's the end of this slideshow. I'll see you soon for the diabetes one. Thanks.